So now we will begin with our first lecture, an approach to challenging cases in pulmonary pathology by Dr. Raghavendra Pillappa, who is Assistant Professor, VCU Health System, Virginia, USA. And the chairperson for the session is Dr. Anuradha C.K. Rao, Professor, Enipoya Medical College, Mangalore. Madam has got 24 years of working experience, and her areas of interest are nephropathology and oncopathology. She has over 67 articles published in various international and national journals. Madam has chaired various conferences, workshops, and guided postgraduates for their theses, paper, and poster presentations. Thank you, Anuradha Madam, for accepting our invitation and for chairing the session. Over to you, ma'am, for introducing the speaker.
Good morning to all delegates and all dignitaries online. First of all, I would like to thank the organizing chairperson, Dr. Basavaraj Bommanahalli, Head Department of Pathology at Gadag Institute of Medical Sciences, and the organizing committee for presenting me with this opportunity to chair this wonderful session. It gives me immense pleasure to introduce Dr. Raghavendra Pillappa. I have had the good fortune to listen to 2 of your lectures, sir, and I found them really enlightening. Thank you so much. Actually, it gave me immense pleasure to introduce you today. And Dr. Raghavendra Pillappa has done his undergraduation at Sri Devaraj Medical College 2001, following which he did his MD at KIMS Hubli and secured the gold medal for highest marks in pathology by the RGUHS. Following that, he has worked as assistant professor in 2008 at MVJ Medical College and Research Hospital, Bangalore. He moved on to International American University, St. Lucia, and was there till 2012, following which he has done his residency in United States at University of Tennessee Health Sciences. This was followed by fellowships in 2 branches, that is in General Surgical Pathology at Mayo Clinic, Rochester, and Pulmonary Medicine in the same place in 2017 and 2018 respectively. His special interests include interstitial lung diseases and breast pathology. He is a full-time assistant professor at Virginia Commonwealth University School of Medicine and Health Sciences. Now, I have had the good fortune to listen to 2 of his lectures, as I have already told you, and both those were quite enlightening as well as very simple. He tells in a very simple manner, very lucid, very clearly. He is also 2 more things I found out about him was that he's authored chapters, I think 3 chapters in color text atlas and textbook of pulmonary pathology. Really great, sir, at such a young age. Then he's also section editor for social media in Archives of Pathology Lab Medicine and a reviewer for American Journal of Clinical Pathology. So without delaying further, let's move on to you, sir, for your session.
Hi, good morning, everyone. Can you all see my PowerPoint?
Yes.
Okay, great. Thank you, madam, for your wonderful introduction. I really appreciate your kind words. I hope I can live up to the expectation and also the reputation and everything. So, today's talk is very interesting because I picked up 4 different challenging cases in pulmonary pathology. All 4 of them are in totally different directions. And these are really very practical kind of problems you face when you sign out pulmonary pathology cases. So I have nothing to disclose. I have no financial interest in giving this lecture. So my learning objectives for today is to recognize the spectrum of different entities when small blue cells are encountered in a lung biopsy specimen. So we are talking about a small biopsy specimen. And then the second objective is approach to an unsuspected vascular thickening. Third objective is to identify the unusual spindle cell neoplasm when masquerading as a common tumor, common spindle cell tumor. And then the fourth objective is to understand the spectrum of neuroendocrine proliferations beyond the diagnosis of carcinoid tumor. So let's look at the first objective with a example, which I feel would give you an idea of practical aspects when you're dealing with such kind of specimens. So we got this biopsy. So this is an endobronchial biopsy in a 68-year-old man with abnormal CT chest. So the history is very simple. We get as minimal history as possible, like how we used to get in India. So in India, I used to see they used to just write one line, one sentence in the paper and send to us. So exactly the same thing. The practice is the same. So here also we get the same thing, one sentence. But the advantage here is we have access to electronic health records, so we can go back and look at the patient's chart and also look at the imaging, look at all the previous medications and everything. So that's an advantage because of the electronic health records. But otherwise, as far as the history is concerned, it's the same. We get one-liners. It's true for there, it's true for here. So you can see the endobronchial biopsy. Again, the difference between an endobronchial and transbronchial biopsy is alveolated lung parenchyma. So which you don't see in an endobronchial biopsy because the interventional radiologist usually samples the specimen or the tissue as he's seeing through the bronchoscope. So it does not pass to the wall of the airway into the alveolated lung parenchyma. So in an endobronchial biopsy, you will not see alveolated lung parenchyma. But in a transbronchial biopsy, where the needle passes from the airway into the alveolated lung parenchyma, you will also see alveolated lung parenchyma. So this is an endobronchial biopsy, and you can see there are 3 tissue fragments, and you can see the bronchial mucosa lining them. And there's also submucous glands beneath this mucosa also. And there are some detached epithelial cells which you can expect to see in this type of biopsies. And then you can see the smooth muscle in the wall and also the bronchial mucosa. And you can see these blue dot-like cells, which are nothing but lymphocytes. And many of them are crushed because of the artifactual changes introduced in these kind of biopsies. And then out of these 3 tissue fragments, one of them had this diffuse blue cells or diffuse infiltrate by this small cells. And as you can see here, most of them has got this crushed artifact. When you go to the periphery of this fragment, you see some cells which are crowded, some cells which are overlapping, maybe some cells which has got nuclear molding or nuclear overlapping. Otherwise, it has got very high nuclear cytoplasmic ratio with scant cytoplasm, and it has got hyperchromatic nuclei. And then, so the differential diagnosis was brought for us when we looked at this biopsy. And obviously, since an endobronchial biopsy, we are expecting a hilar kind of mass lesion in the lung. And we don't know if the patient was a smoker or non-smoker. So let's assume the patient is a smoker. So in that scenario, the most common or the top of the differential diagnosis would include a small cell lung carcinoma. So when we did the immunostains, the reason why we did immunostains was on H&E morphology, it's all crushed cells, tumor cells. There was not much of viable cells for us to make a diagnosis on H&E. Like I showed you, it's all crushed tumor cells. That's why we need to resort to immunohistochemistry to make a diagnosis. So when we did immunohistochemistry with a panel of stains, the first stain was TTF1. As you can see here, it's a nuclear staining and it's strongly positive. And as you know, most of the small cell lung carcinomas are TTF1 positive. And again, it's not specific for pulmonary origin because small cell carcinomas of thymic origin can also be TTF1 positive, and also other origin small cell carcinomas can also be TTF1 positive. So that's why TTF1 positivity, that doesn't mean that it's a small cell carcinoma of lung origin. The other markers were neuroendocrine markers, synaptophysin, chromogranin, CD56. There's a newer marker, INSM1, available too. But again, we will not go into that. But for this case, synaptophysin and chromogranin were positive, and you can see in this slide, the synaptophysin was strongly positive. In addition to that, Ki67 showed more than 90% proliferation rate. Again, this is important, especially in these kind of specimens where it's all crushed, where you can't make out the H&E morphology adequately. In these cases, it's very helpful to differentiate it from a carcinoid tumor where you'll find a lower Ki67 proliferation rate. So that's why it's very important in this case that it's a very high proliferation rate. So it falls into the spectrum of high-grade neuroendocrine carcinoma, such as small cell carcinoma, like in this case, as we were thinking. So is that enough? Small cell morphology on H&E means like with crush artifact, TTF1 positivity along with strong synaptophysin, along with increased Ki67 proliferation rate. So is this combination enough for the diagnosis of small cell lung carcinoma? Again, mind you, if you take out the neuroendocrine markers aside, so the neuroendocrine markers may be negative in about few cases, like 5 to 10% of cases. Otherwise, most of the small cell lung carcinomas can be positive as far as the neuroendocrine markers are concerned. So the question is it enough? Do we need anything more? So what about keratin? So pan-keratin was negative in the tumor cells. And again, you can see the internal control, the glands, the epithelial cells which are lining the glands, they're all positive. So it's very important when you're looking at an immunohistochemical stain to look at the internal control. If you don't have an internal control, look at the on-slide external control to make sure that the stain is working adequately. And it's very important that you run this control on each and every stain and each and every case. So in this case, the pan-keratin was, so the cyto part is excluded because that's the older terminology where they used to add the prefix cyto for keratins. We don't use it anymore. It's just pan-keratin. Or if you say CK7, it's not CK7, it's just K7. Keratin 7, keratin 20. So the cyto is the old terminology. The newer terminology is just keratin. So I tend to add keratin 8/18 along with the pan-keratin because 18 is one of the type of keratin which is missing in the AE1, part of the AE1, AE3. So the keratin 8/18 was also negative with a good internal control in this case. So what do we do now? The keratins were negative, but TTF1 is positive, synaptophysin, the neuroendocrine markers are positive, and the proliferation rate is very similar to small cell carcinoma. Do we go ahead and find out this case as small cell lung carcinoma? So that's the question with this case. So we did additional stains because whenever you think the morphology of a biopsy specimen is that of a small cell carcinoma, but the keratin is negative, then it's important that you exclude other tumors. Most importantly, squamous cell carcinoma, which is poorly differentiated, which can have a basaloid kind of features. That's one of the most important tumors to be excluded because the treatment and the management is completely different than small cell carcinoma. So the P40 stain is very helpful in that regards. Then the other most important is lymphomas. So for lymphomas, you can start with CD45, and then if that is positive, then you can add on B cell and T cell markers. Some people also add on to mantle cell, cyclin D1, all those markers. We generally take it to our hematopathology colleagues and they will figure it out for us. And then the other most important tumor you need to exclude is melanomas. Melanomas are keratin negative and they're SOX10 and S100 positive. I prefer SOX10 because that's a much more cleaner stain. It's a nuclear stain, unlike S100, which is a nuclear and cytoplasmic stain, and it's more of a dirty background. That's why I prefer SOX10 over S100. Then primitive neuroectodermal tumor, CD99, it's useful it's useful only as a screening tool, not for confirmatory. For confirmation, you need additional testing. So in this case, the keratin, even though the keratin was negative, so the multiple other markers were also negative. That means the markers were P40, CD45, SOX10, CD99. So it's excluded all these other entities. So once we excluded all these entities with this morphology, with strong TTF1 and synaptophysin, we can definitely render a diagnosis of small cell lung carcinoma, but make sure that you exclude other entities. And also it's important that you check the chest CT imaging for the patient to see if the mass lesion in the hilar region. And it will be helpful if the patient is also a smoker, because as you know, small cell carcinomas are usually central in origin and they're commonly seen in smokers. So if you have this clinical findings fitting into your case, into your morphology, then you can go ahead and sign out this as small cell lung carcinoma. But hold on, what about the rare emerging entities? What about the new entities? So the two entities I want to bring your attention to, one is thoracic SMARC A4 deficient undifferentiated tumor. I saw a couple of cases, few cases at Mayo Clinic. At VCU, I did not see any of this case. So again, they can have a small cell morphology sometimes. They can be synaptophysin positive. They can show TTF1 expression, but the clincher for the diagnosis is this specific immunohistochemical stain that is called BRG1 or SMARC A4 protein. We don't have this immunohistochemical stain. We usually send it out as send out to Mayo Clinic for this immunohistochemistry test, because we don't have the volume for us to substantiate bringing this stain in-house. So if you see loss of SMARC A4 protein by immunohistochemistry, then you should be thinking of this thoracic SMARC A4 deficient undifferentiated tumor, because the cells can look exactly very similar to small cell carcinoma. And again, you can see some studies also mentioning they can also have some rhabdoid looking cells also. Again, we are still learning about this newer entities, so we'll find more and more studies coming up on this and our understanding would be better. Then there is other emerging entity called SIC DUX4 rearranged and cyclin B3 rearranged tumors. So these are round cell sarcomas and they are usually CD56 positive, they are keratin negative and usually seen in younger adults, not in older individuals like what you expect to see in small cell carcinoma. And again, smoking history is generally not present. And these are again emerging entities, but they can have similar morphological appearance. So it's important that you keep that in mind. But according to the new WHO book, which is the 5th edition is out on the thoracic tumors, if you have not bought that, you should go ahead and buy that. But I don't have any financial interest in that. But it's a good book. So the keratin negative small cell lung carcinomas, they mention that it's very rare. And before making the diagnosis, you have to make sure that you have to exclude other entities. And neuroendocrine markers positivity. And they also mention RB1 loss and also aberrant P53 expression. So those are the criteria useful if you encounter a keratin negative small cell lung carcinoma. Otherwise, if your keratin is positive, it usually gives you a dot-like or a delicate type of perinuclear staining. It's not like very strong staining. It's very dot-like or perinuclear staining. And if you have that, then you're fine. Along with the other morphological features on H&E, then you're fine. You can make a diagnosis of small cell lung carcinoma. I think that's my first case and the first learning objective. And again, it's the most important objective I wanted to make sure is you understand the differential diagnosis of the small cell in a small biopsy and try to exclude other entities which can have a similar morphological appearance on H&E stain. And when you're using multiple immunostains with keratins and everything, it's important to have that approach of looking at keratin first and followed by other markers. Because if you end up looking synaptophysin or chromogranin first and not look at keratin, then if you think that synaptophysin is positive and overlook the negative keratin, then you might end up in a wrong path. So because melanomas can also be synaptophysin positive, they can be keratin negative, of course. So you might end up in a wrong path. So it's important you have that approach of looking keratin first and then subsequently by other immunohistochemical stains. So if you have any questions, I can take at the end, or if you have any questions, you can also type in the chat box. I can look it up at the end of my talk and answer your questions. So let's move on to the second one. So the second learning object is very vague. Means it's very vague, an approach to the unsuspected vascular thickening. Again, it can be multiple things, right? It can be pulmonary hypertension to chronic thromboembolic disease. There can be so many things which can be seen giving rise to vascular thickening in the lung. So this is a scan slide of a wedge resection of the lung lobe. So this is a 60-year-old woman presented with unilateral recurrent pleural effusions and also shortness of breath. So you can see some prominent blood vessels here. Otherwise, you can see small airway. And then you can see the pleura, which is slightly thickened. And then you can see more of these blood vessels here. And then you can see some lymphoid aggregates here. So that's what you can see in this at this magnification. On little higher magnification, other than the alveolated parenchyma with macrophages, the pigmented macrophages, you can see this thickened blood vessels. And this blood vessels has got some eosinophilic deposits. And we also came to know that this patient also has possible pulmonary hypertension. Again, pulmonary hypertension, clinically, it is defined as more than 25 millimeters mercury elevated pulmonary vascular pressure. And also the pulmonary capillary wedge pressure should go down. The mean pulmonary arterial pressure should go up. So again, it's a clinical definition, similar to how we diagnose systemic hypertension by checking the blood pressure. It's similar for pulmonary hypertension too. So check at the pulmonary vascular pressures. So now you can see the thickened blood vessels here very prominently seen with these eosinophilic deposits. And if you look at this, this is pleura. So the pleura is also thickened with the same kind of deposits, and in between the alveolated parenchyma, it looks fine. So it looks unremarkable other than the intraalveolar pigmented macrophages. And there were areas where there are this nodular kind of aggregates of this blood vessels, thickened blood vessels, and also in between the septa was thickened with the same eosinophilic deposits. So you got the alveolar septa thickening, you have the blood vessels, the walls of the blood vessels thickened by these eosinophilic deposits. And then when we did a Congo red, you can see the salmon red color of these thickened areas of the blood vessels highlighted. Even at this magnification, you can see they are highlighted. Little higher magnification, you can see the salmon red color. So it confirms that there is presence of amyloid. So again, more higher power on the same thing. So eosinophilic salmon red color. And when you polarize it in a cross-polarized light, it will show you apple green birefringence. So if you don't have polarized light, there's one more histochemical stain, which is called sulfated Alcian blue, which you can do instead of Congo red. I feel one of the most difficult stains to interpret in pathology is Congo red, because it's so sensitive for so many things. You have to have a thicker section, and you have to have a perfect staining protocol for you to get that perfect color. And we have seen that when I was in Mayo Clinic looking at the consult surveys, the most common question about amyloidosis is, the question was very simple as, is this congruent positive or negative? That's the question. So because they used to struggle, different labs used to have different protocols, and the sectioning is so important that they used to struggle with staining of this congruent. So there was an alternate stain which you can use if in case. I generally use both the stains, congruent and sulfated Alcian blue, because 2 is better than 1. That's why I use both the stains. And the color I expect to see for sulfated Alcian blue is this teal color. So teal color, that's what is amyloid positivity. So when you see this teal colored staining, not the yellow color, that's the counter. You can see the red blood cells are all staining yellow. So teal color, then that's amyloid positive. So this is our sample pathology report. So after mentioning amyloidosis, so we have to say if it is forming nodules, if it is involving vascular and pleural involvement, as in this case, and also mention about how we demonstrated this by congruent stain by apple green birefringence, and also mention about the location of this amyloid deposits, if it is in the alveolar septal location or vascular, depending on what type of stains you have used. And you can, if you go back to the case, I told you that the clinical presentation was that of pleural effusion. So you can connect the dots or connect the link that the pleura was thickened with amyloid deposits that would have given to this pleural effusion. And because the vessels were involved with the amyloid deposits, that's why that has led to the pulmonary hypertension. So you can connect the dots in this case with the microscopic findings, what I showed you. And all the amyloid cases, we try to type them with liquid chromatography mass spectrometry. And in this case, it came back as AL lambda type amyloid deposition. Again, briefly to tell you about amyloidosis in lung, it can be localized or diffuse. Localized is primary amyloidosis. Again, it can be nodular pulmonary amyloidosis or tracheobronchial amyloidosis, which is the least common form. The nodular pulmonary amyloidosis, you'll find these amyloid deposits in one or more, forming one or more tumefactive or the nodular kind of areas consisting of amyloid deposits. Then in the diffuse type, which is part of the systemic amyloidosis, usually you find the amyloid deposition within the nodular interstitium and blood vessels. And again, in both types of amyloid, localized or diffuse, it is AL subtype. You can also expect other subtypes. Again, the mass spectrometry would tell you the type of amyloid, and the treatment depends on the type of amyloid. And the most important takeaway from this case for you is, once you diagnose amyloid, it's very important to differentiate a primary process from a secondary process. That is, if this amyloid deposition is secondary to hematolymphoid processes, such as multiple myeloma or mild lymphoma or lymphoplasmacytic lymphoma. So it is very important that you get the patient worked up for this systemic hematolymphoid processes and exclude that. Because in our patient, this patient ended up having a multiple myeloma. That's why this was a secondary kind of process. So they started treating her for multiple myeloma, in addition to what they were doing for a lung amyloidosis. So that's the takeaway from this case. That is, so nobody suspected that this was amyloid when she presented with pleural effusion and possible pulmonary hypertension. but it ended up with amyloidosis, and then nobody knew that patient had multiple myeloma unless we told them that there is amyloid in the lung. You have to go back and look at our entire body to make sure that there is no hematolymphoid process going on in our body. So that was the takeaway from here. And otherwise, if you take away amyloid from the blood vessel thickening, so the other conditions which can cause blood vessel thickening is pulmonary hypertension. But like I mentioned to you, pulmonary hypertension is a clinical diagnosis where you check the pressures, and it's not a pathology diagnosis unless you see plexogenic lesion under microscopy. If you see multiple smaller capillaries forming an aggregate lined by endothelial cells, then that's a plexogenic lesion. That's diagnostic of pulmonary hypertension. That's enough. But otherwise, if I don't see it, if I just see thickening of the blood vessels, the branches of the pulmonary artery in the lung, I just mention that as medial hypertrophy or intimal hypoplasia and ask them to correlate with pulmonary vascular pressures. So that's usually my approach whenever I see vascular thickening. So I think that finishes my second objective. So how are we doing on time? Are we doing okay on time? So let's move on to the third one. My third learning objective is to identify the unusual spindle cell neoplasm when masquerading as in common tumor, common spindle cell tumor. So you can see this was a 4 centimeter spindle cell tumor in the left lower lobe of the lung. To the right side of this image, you can see the alveolated lung parenchyma, and then you can see this big tumor here. And it's a fairly well demarcated tumor. And this image you can see still it's fairly well demarcated, but it's closer to a small airway here. That's an airway epithelium here, and then you have this alveolated lung parenchyma. But otherwise, when you look at these cells, they are oval to spindle shaped, and some areas it's intersecting. Otherwise, you don't see obvious mitosis or ATP at this magnification. Little higher magnification, you find some bigger cells, but still oval to spindle shaped. And it has got abundant cytoplasm. And the blood vessels, you can see some small capillaries. There's some areas of hyalinization, some collagen type structures in the stroma or in the cytoplasm between the cells here. And then if you look at this area, the cells are becoming slightly bigger. The cells are becoming slightly bigger and started to have this vesicular kind of chromatin, but there's no prominent nucleoli. There's several multiple smaller kind of nucleoli, but it's definitely not as bland looking as we were thinking when we first saw it on the low power image. So the differential diagnosis, when you see something like this, the first thing you think of is solitary fibrous tumor of thorax. The other entities is, let's only talk about common things. There can be endless broad differential diagnosis. Synovial sarcoma, then neural tumors, schwannoma. Again, you don't have Antony A, Antony B pattern. Then thymomas. Again, we will take out the thymomas in this case because the CT imaging did not show any thymic mass or anything. And patient did not have any history of previous thymomas to think that this was a metastatic thymoma in the lung. So, but let's consider the topmost one, solitary fibrous tumor of the thorax. So the most important stain to prove that it's solitary fibrous tumor is STAT6. So in this case, it was negative. So we have a dual stain in our lab. We have optimized STAT6 with MUC4. So the STAT6, you can see the control here. It's a nuclear stain. It's brown here, and the MUC4 is red color. And again, the MUC4 is for low-grade fibromyxoid sarcoma. So we use this dual stain especially in spindle cell tumors, bland spindle cell tumors in small biopsies and needle core biopsies. Because the most commonly the differential diagnosis is between solitary fibrous tumor and low-grade fibromyxoid sarcomas. So, and we have had fairly good success differentiating one over the other. If it is STAT6 positive, then the chances that it is solitary fibrous tumor is higher compared to MUC4 positivity. Unlike STAT6 positivity, then it's low-grade fibromyxoid sarcoma. But in this case, both were negative. STAT6, MUC4, the dual stain was negative. The only stain positive was smooth muscle actin. And we did other stains as well. Keratin. Keratin is important because if it is keratin positive, you can also have a spindle cell carcinoma, which you can expect, which is much more common in the lung, which is nothing but the sarcomatoid carcinoma of the lung. But even though the morphologically doesn't fit that, you should definitely have that in your mind when you're getting an immunohistochemical stain or profile. But in this case, the keratin was negative, and then EMA, epithelial membrane antigen, that was also negative. Some synovial sarcomas are EMA positive, that's the reason. Desmin was negative, so that counters the rhabdomyosarcoma. S100, melanoma. BCL2 is positive again in solitary fibrous tumor. CD21 for follicular center, follicular dendritic cell sarcoma. CD23, same. ALK for inflammatory myofibroblastic tumor. ALK for a vascular lesion. CD34, similar, but CD34 is generally positive in solitary fibrous tumor. SOX10, S100, both for melanoma. So you can see the multiple stains were negative. And we also did FISH. The reason why we had to go this much doing all kind of things were, when we received this case from outside, they had called this or diagnosed this case as solitary fibrous tumor. So the patient was coming to our institution for further treatment. So we had to confirm the diagnosis. But when we looked at the morphology was looking solitary fibrous tumor-like, but something was missing. And when we looked at the stains, the CD34 was negative and the STAT6 was negative. So that was a red flag for us. And then we went back and looked at the cells, and they were little more pleomorphic than what you expect to see in a solitary fibrous tumor. So those were all the red flags for us to think, to work up this far to make sure that it's not something else. And the FISH was negative for synovial sarcoma and also Ewing sarcoma break apart region. So extensive workup was negative. And further, we also did next generation sequencing sarcoma fusion panel for all these genes. You can see it's again a send out test. They checked for all these genes, but the ones which I've put a box is NAB2, STAT6. That's the one for solitary fibrous tumor. So including those were negative. So no fusion RNA was identified. So since there was no positive features for solitary fibrous tumor, that means no morphological clues such as tag-on branching vessels were not present. And again, the keloidal collagen was very minimal. And again, solitary fibrous tumor can have multiple phases. It can look like many things, but still STAT6 negativity along with negative CD34, it's a good way to exclude solitary fibrous tumor. And also, in addition to that, the chest imaging showed no pleural attachment of this tumor, which is a strong feature against the diagnosis of solitary fibrous tumor. So that's how a classic solitary fibrous tumor would look like. You have oval to spindle shaped cells with keloidal type collagen in the background. And usually they have described it as a patternless architecture. Sometimes you can also have storiform architecture. And most of them are slow growing. 10% of them are aggressive and usually have a pleural based soft tissue mass. And genetic hallmark is fusion of NAB2 STAT6 genes, which both are located on chromosome 12. And again, it's important that you don't do this fusion check by PCR technique. It's rather preferred to do by multiplex sequencing assay, like how NGS panels are done. But the cheaper alternative is STAT6 immunohistochemistry, and consistently the studies have shown that it's a sensitive and specific surrogate for all fusions, what we expect to see in case of solitary fibrous tumor. So in this case, the STAT6 immunohistochemistry was negative. Along with that, we did everything possible to make sure that there are no fusions, means obviously there was no fusions in this case, and thereby we are able to exclude solitary fibrous tumor in this case. And finally, it was unclassifiable because there was no fusions and it was not showing any differentiation based on any immunohistochemical stains. So we had to classify that as unclassifiable, even though that doesn't look good, but that's actually something. Maybe in the future studies, we'll know what exactly these tumors are, the behavior and the morphology of these tumors, if some more studies comes up. So again, there is something, when you're talking about solitary fibrous tumor, there is a risk stratification model by Demiko's criteria. And usually it has got 4 variable risk stratification model to predict the development of metastasis in solitary fibrous tumor: age, tumor size, mitotic count, tumor necrosis. So you can see in the table, based on this, a score is given, and based on the addition of this numbers or score, it is classified into low, intermediate, and high category. And higher it is, then the higher chance of metastasis in solitary fibrous tumor. Like I mentioned to you, solitary fibrous tumor, they're mostly benign, but 10% of them can be aggressive. And there is also a version called dedifferentiated solitary fibrous tumor, where you'll find a malignant transformation of a solitary fibrous tumor into dedifferentiated areas. So it's very important that you remember this entity. Can you unmute, please? Can you mute? I think that finishes my 3rd objective. The last one is the 4th, and the last one is. Can you mute, please? Okay, the last objective is to understand the spectrum of neuroendocrine proliferations beyond the diagnosis of carcinoid tumor. So again, this was a wedge resection, and you can see there is a nodule. So the wedge resection was done for a lung nodule. Again, you can see one nodule here, but there's also one more nodule here as well. But when we looked at the remaining sections, there were multiple additional nodules here of varying sizes. You can also see some of them smaller tumor cell nests in the air spaces, floating in the air spaces as well. And then on higher magnification of this different sites of the nodules, you can see it has got this fine nuclear or fine granular nuclear chromatin. And it's not exactly, what do you say, a storiform kind of pattern, but it has got that meningothelial whorls kind of pattern. But otherwise, it has got neuroendocrine morphology. So definitely you and me can agree that it's neuroendocrine proliferation. And as you know, neuroendocrine proliferations can have various growth patterns, ranging from trabecular, it can be organoid, solid, pseudoglandular. It can be so many different types of pattern. There was also STAS present in this carcinoid kind of proliferation or neuroendocrine proliferation. So as you know, STAS is nothing but outside the circumference of the tumor. If you see tumor cell nest floating in the air spaces, that is called spectral air spaces or STAS. So that's what we saw. And then in other areas, the airway epithelium had this neuroendocrine proliferation, but it was not going beyond the basement membrane. It was just restricted to the epithelium of the airway. So this is nothing but the linear or nodular collections are nothing but neuroendocrine hyperplasia. There were some smaller nodules. So the nodules which I showed you earlier, they were more than 5 millimeters. So as long as they're more than 5 millimeters and they're neuroendocrine, it's a carcinoid tumor. But if they're less than 5 millimeters or equal to 5 millimeters, and you can see the airway here, and if they're beyond the basement membrane of the airway into the surrounding tissue, and the size is equal to or less than 5 millimeters, then it's carcinoid tumorlets. One more carcinoid tumorlet present here. So now the question is, so I showed you neuroendocrine proliferation. You have neuroendocrine hyperplasia, you have tumorlets, and you have carcinoid tumor, all different sizes of neuroendocrine proliferation. So the question is this dip neck? So that's the question. So what is dip neck? So diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Excuse me. So it's a rare entity. It requires correlation of everything: clinical, radiologic, pathologic correlation. What you see is the spectrum of neuroendocrine proliferations of different sizes: neuroendocrine hyperplasia, carcinoid tumorlets, and carcinoid tumor. And generally, the patients can be asymptomatic, they can be symptomatic with obliterative constrictive bronchiolitis. And chest imaging usually shows evidence of airflow obstruction, such as mosaic attenuation or air trapping. So that's a radiologic abnormality. So there are several conditions where you can see neuroendocrine cell hyperplasia or carcinoid tumorlets. Here are the list of conditions: tobacco smoke, diffuse pan bronchiolitis, asthma, cystic fibrosis, bronchopulmonary dysplasia, bronchiectasis, high altitude exposure, pulmonary fibrosis, and reactive changes adjacent to a neoplastic process, and as a component of dip neck. So you can see the dip neck is at the last. So before diagnosing dip neck, which is a pre-invasive lesion or a pre-invasive condition, you have to make sure that it's not secondary to other conditions like I've listed here. And if carcinoid tumors are present, that doesn't mean that it's dip neck. It can be present, but not required for the diagnosis of dip neck. So whenever you have multiple different kind of lesions ranging from neuroendocrine cell hyperplasia to carcinoid tumorlets and carcinoid tumor, and if you cannot find a reason that it is secondary to something else like what I've listed in the previous slide, tobacco smoking or other neoplastic conditions or high altitude or asthma or chronic small airway disease, if you cannot find a possible explanation, but still you're finding this multiple different neuroendocrine proliferations, then you can raise the diagnosis of dip neck. And many a times what happens is, like in this case, the case which I'm presenting, here the clinical manifestation was not airway obstruction. It was more of a mass lesion, more of a nodule due to carcinoid tumor. So in this case, the Dipneck diagnosis is unlikely. It's more of a carcinoid tumor. That means what I'm trying to say is, along with carcinoid tumor, you can expect to see carcinoid tumorlets and neuroendocrine hyperplasia. It's not that whenever you find this combination, it's always Dipneck. No, Dipneck is very rare. Only if you can't find an explanation and if you have a radiological demonstration of mosaic attenuation and airway trapping, along with clinical manifestations of airway obstruction. That means the patient should have breathing difficulty or shortness of breath, that kind of a thing. Then you think of Dipneck, which is a multidisciplinary diagnosis where you talk with the pulmonologist, talk with the radiologist, and you have neuroendocrine cell hyperplasia, neuroendocrine proliferations, and a pathology. Then it's a diagnosis of Dipneck. And the other important point is, if you have multiple carcinoid tumors in a setting of Dipneck, they are not considered as intrapulmonary metastasis, but they have to be considered as independent primaries and the stage is low. If you consider them as intrapulmonary, the stage is high and it's much bad prognosis, but here it should be considered as independent primaries. So I think that's about my fourth objective. So I discussed 4 different cases with 4 different objectives. To summarize everything, keratin negative small cell carcinomas, they're very rare, but rule out other entities. Also keep an eye on the emerging entities like thoracic, SMARC A4, and BCAR, cyclin B3, those entities. Amyloid in the lung can present with various forms, but important to exclude systemic form of amyloidosis if the patient has hematolymphoid process. If the patient has a lymphoma or something like that, it's very important that you suggest that workup. And then spindle cell tumors of the lung, not all spindle cell tumors are solitary fibrous tumor. STAT6 is a very good immunostain, which you can use it to exclude a spindle solitary fibrous tumor. But before that, the spindle cell tumors in the lung most of the times is sarcomatous carcinoma. So make sure you rule out sarcomatous carcinoma before entering into the spindle cell tumor category. And again, about the neuroendocrine proliferation, I told you it's a spectrum of lesion. They can present as a nodule. They can present as airway obstruction. If they present as nodule, then it can be just carcinoid tumor associated with neuroendocrine hyperplasias. But if they present as airway obstruction, not as nodules, and if you see this different kind of spectrum of lesion, and if your radiologist says that on CT imaging there is mosaic attenuation or airway trapping, then you might be seeing a case of Dipneck, which is a rare entity. I think with that, I would like to thank Dr. Harish Parmi and Dr. Basavaraj Bommanalli for inviting me, giving this opportunity to talk to you today. And here are my selected references, and let me open the chat box.
Thank you, Doctor. That was a wonderful presentation. I think 4 cases which helped us to understand the different differential diagnosis and the markers that can be done along with that. Dipneck, I always wondered what it was. Today you have explained it so beautifully and told us the main criteria which we can take from that and then ensure that it's not a Dipneck or it is. Most of the time when we see this, it's usually in post-mortem cases. I'm yet to come across this in as a biopsy. And then about that spindle cell lesion, actually we quite often face this, not just in lung, elsewhere also. So you showed us what exactly how we should proceed. And there are some questions regarding the same. I'll come to that. Then unsuspected vascular thickening. Amyloid is one thing which we usually do not think of whenever we get any case. Last thing we think of is amyloid. So you've told us correctly that you should initially rule out amyloid and then think of other things. And of course, small blue cell tumor is always a difficult diagnosis, especially because in the lung it comes as a crushed tissue, a crushed section. So thank you so much for taking us through these 4 challenging cases and discussing all this immunohistochemistry. Now coming to the questions, The first one is by Dr. Harish. He says, how about metastasis to the lung? Round cell variant of synovial sarcoma in the first case. Anything you would like to add?
Yeah,
The first case, he says round cell variant of synovial sarcoma.
yeah, again, the morphology, synovial sarcoma will have a distinctive kind of presentation and everything. In this case, again, you have to correlate with the clinical presentation and also the imaging. Most of the times you'll find an answer. And common things first. If you're thinking of a smoker with a higher mass and everything, then you're more thinking in terms of small cell carcinoma. But if you're thinking a younger individual and then a bigger mass lesion, and then generally EMA and the fish should be positive for synovial sarcoma. We try to exclude that by the fish should be helpful to exclude that. So many times, if you have differential diagnosis of such sort, you have to do additional testing to exclude those. That's the only thing. Otherwise, morphology, they will all look similar. And it's important that you go that extra step and do fish studies to exclude a synovial sarcoma. That's what I can tell.
Okay, the next question is by Dr. Bharati. This is, I think, about the spindle cell lesion. How do you explain the SMA positivity? Can we consider leiomyomatous hamartoma?
SMA positivity, it's not very specific stain. SMA can be positive in so many things. Again, I'll tell you, the biggest truth about immunohistochemistry is those are false positive things. Ultimately, the morphology still is the king. So morphology is still important for you. And leiomyomatous hamartoma, again, those are rare entities. And especially in women or something like that, I would consider. But here it was a primary mass lesion in the lung. And it was more pleomorphic for just an hamartoma. Hamartoma, you're thinking of a mixture of normal tissues in an abnormal location. But here it was a tumor. It was a neoplastic lesion. So I would not consider a non-neoplastic kind of entity in the differential diagnosis here, because there were some rare mitosis and rare pleomorphic cells here. So again, the SMA positivity, SMA can be positive in many things.
And I think in this Desmin was negative also, if I remember right.
Exactly. Yeah.
So,
Again, it's easy to get into. Sorry?
Any chance of doing HCal Desmon? Because sometimes Desmin can be negative, but HCal Desmon can be positive in smooth muscle tumors.
True. We did not do, because we don't have that Cal Desmon stain.
This thing is so many times it has happened for us. So what we do now is we do all three markers.
Yeah.
And then
exactly.
check. Just to be
exactly.
sure.
Yeah, exactly. Most places, that's what we're getting to, that we're trying to do 2-3 markers to confirm or rule out a differentiation. Yeah. For example, I was telling you, keratin, we do 2 or 3 keratins. Again, mesotheliomas is something where we do so many markers, because when you enter into the spindle cell or sarcomatoid mesothelioma category, the mesothelial markers are useless. Because they're mostly negative. Only positive marker would be keratin. So what do you do? So you end up doing 2, 3, 4 markers, and then you're still at the same starting stage. You're still at the same morpho. You're looking at the H&E, and you will be at the H&E back again to make a diagnosis. Excluding spending all the money on immunohistochemistry, you will be back at H&E to make the diagnosis. So that's what I was telling you.
You have to just correlate with everything.
Exactly.
Okay, the next question is by Dr. Kumuda. She says, is Ki67 useful in the spindle cell sarcoma? I could not appreciate the atypia.
Atypia. Yeah, Ki67. Again, like I mentioned to you, I just showed you the snapshots, right? if you see the entire slide, you will definitely appreciate the ATPR, believe me. So for the presentation, we just show you some snapshots, but I would definitely prefer H&E, ATPR evaluation, mitosis, 10Ki67. In lung pathology world, we are very old school. Even for carcinoid tumors, for grading and everything, we don't use Ki67. Unlike GI people and other subspecialties where they use Ki67 for grading the carcinoid tumors or neuroendocrine tumors. But spindle cell sarcoma, no, we don't use Ki67. It's still morphology and your ATPR, those things we use.
Okay, so I think lastly was again Dr. Sunit, a very informative, good presentation, Dr. Raghavendra, which I think everybody will agree with that. It was a wonderful presentation. So I think we come to anything else you would like to add, sir?
No, nothing else. Hopefully it is helpful. And my basic idea was to give you some practical navigatory kind of approach kind of pathways rather than giving you what is in the books, because you can go back and read in the books, but the practical problems we face when we are dealing with these kind of cases, that's what we have to share with our younger colleagues so that it's easier for them to figure out these kind of cases rather than spending more money and wasting it on immunohistochemistry or something. It's very important that you use the resources very diligently and very, very to the best of your efficient way.
Another important takeaway was about that pan-keratin not having 818 in it. That was also, yeah. Actually, till now, I too wasn't aware of that. That keratin 18 isn't there in that. So I think I'll have to use that.
I generally use pan-keratin along with CAM 5.2. CAM 5.2 has got 7 and 8, which are low molecular weight keratins. And I try to use that CAM 5.2 and CK818, and then I'm covering all the keratins. I'm not leaving anything away. So if my tumor is carcinoma, it should be positive in one of these. So that means many times mesotheliomas, they're very, like, they can be pan-keratin negative. That time the CAM 5.2 generally helps me. Especially the low molecular weight keratins definitely help in staining the mesothelioma. So that's why I use the combination of those keratins to get the answer.
Thank you so much, sir, for the wonderful talk and the enlightening experience that we've all had. So I thank the organizers for giving me this opportunity to share this wonderful session. He has really taken up 4 challenges in pulmonary pathology and dealt with it beautifully. And I think most of us have had a lot of takeaways from this session. So thank you so much, and over to the organizers.
Thank you.
Thank you, sir. Thank you for that very informative, elaborative, and educative talk, sir. And it was very interactive session. Thank you, madam, for chairing the session. Thank you, sir. Now we will move on with our next lecture.